All right. Good morning, Mohammed. Um,
Good morning.
so this is our next session in our family medicine series by the Medina Clinic called Managing Multiple Morbidities. And what I will do is I will share our screen here so that we can have our slides as we get going. So,
Okay.
Mohammed, as we were getting started, I think you had a question.
Yeah, doctor, I wanted to ask you what kind of pathologies you see on daily basis, mostly in your daily basis in your clinic.
Sure. Well, I think that I think that the types of pathologies that you see, it very much depends on what specialty you are, for sure. So
Okay.
different specialties will see different pathologies, obviously. In family medicine, I would say that the the most common thing that we encounter in patients are multiple chronic medical problems. That's the most,
Mhm.
I would say that's probably the most common thing. So we see a lot of acute things for sure, but in family medicine, your typical situation is a patient with diabetes or pre-diabetes, somebody with hypertension, cholesterol issues, the things that result from the things that can result from a poor diet, things that can result from alcohol
Mhm.
use. A lot of mental health, a lot of mental health is involved.
Okay.
Basically, a lot of lifestyle things are sort of are sort of the reasons why we see a lot of multiple coexisting medical problems. So that's pretty much the most common thing. So it's interesting, as a family physician, you have to be good at managing multiple morbidities, essentially. I mean, you have to be good at managing a lot of issues. And in sports, there's an analogy where you have to be like if you play, I don't know, in basketball there's something called a point guard. I don't know, in soccer, is there a point
Yeah.
guard?
Midfielder usually they are
Infielder? Okay, all
facilitating
right.
everything. Yeah.
All right. So the person who sort of directs the plays,
Yes, exactly.
um, uh, uh, in American football's the quarterback. So you have to be kind of good at that, and you have to be good at actually managing the processes and the systems in the office. And processes and systems in the office actually is an important part of managing multiple morbidities. In fact, so that's probably the most common thing. So you have to be good at diabetes, you have to be good at hypertension, you have to be familiar with the most up-to-date screening guidelines.
Yeah.
As a family physician, I do a lot of women's health as well. So the most up-to-date guidelines on breast cancer, cervical cancer screening. And also if there's an area of focus, then you'll see more of those things. So oftentimes in the office, I'll see a lot of abnormal uterine bleeding as well,
Mhm.
other primary care gyne issues. Um,
Okay.
so, so yeah, it depends on your specialty, but in primary care, it's a lot of chronic medical conditions. So you have to be good at that,
Mm.
basically. So, but yeah. So let's go ahead and let's see if we can go to the first case here. So, all right, and I believe actually this is the only case for this topic. So let's go ahead and take a look.
Okay.
So this is a case of discontinuous maximus. And actually kind of what this title is kind of referring to is the fact that, when patients have multiple medical issues, well, a lot of times there's a history behind that. There's a history behind that, and they've seen multiple people. And a lot of things typically have already been done already for that patient. So a lot of times, a lot of times you inherit a patient, but you inherit a patient not just with their medical issues, but the medical issues with a history of multiple interventions and multiple, strategies of management that the patient has already undergone. The patient has seen multiple providers already. So a lot of stuff has already happened with those medical conditions. So it's not just, oh, how do I treat hypertension? It's how do I
Yeah.
take care of this patient's hypertension for where they're at? kinds of.
Yeah.
So, so people that are very practical, that are, and also resourceful, they tend to be, they tend to make, I think, that's a strong characteristic of a good family physician. So, okay.
Yeah.
So,
Especially that usually specialists, they look into one disease at a time. So if each one of them treats one, you gotta check all the medications. How is everything stable or on what the patient wants?
exactly. That's exactly right. Exactly. And that's actually, I think, a question in this topic is, is the patient better off seeing
Yeah.
the family physician, or are they better off seeing a bunch of different specialists? So,
Yeah.
so that's a very interesting conversation. And in reality, it's a team in reality. So.
For sure.
All right.
Yeah.
So let's take a look. All right. So a patient presents to your office after moving to your community from a different state. Okay. And that's the thing about of course, the United States is that we have, 50 different states, many
Yeah.
jurisdictions beyond that. And so, different, like one part of the United States compared to another is like two different parts of Europe, kind of. So, all right.
Wow.
So,
Okay.
yeah, you can kind of think of it that way. So she is a 55-year-old, recently divorced marketing executive with a history of recent onset diabetes, long-standing hypertension, moderate obesity, and depression. She smokes half a pack of cigarettes per day. Oh dear, please excuse the typo here. Gets insufficient exercise, travels often, and follows an erratic diet. So you can kind of get the picture of this patient.
Yeah.
By the way, you mentioned, Mohammed, what kind of patients that you see. I will also mention one other thing is that, so you see patients with multiple medical conditions, right? But oftentimes
Yeah.
there's a difference between multiple medical condition in a patient with insurance and with access to specialists, and multiple medical problems in patients without health insurance and with very limited access to specialists. So that there's a difference there.
Mm.
I'll share with you that I work in a community health center, which is my full-time job. And we, more than half the patients that we see do not have health insurance. So we have lots of medical issues to take care of, and we better be good at it because
Yeah.
to have the patient get into a specialist can be very challenging. And so in this particular case, we have someone who's like an executive who, you kind of get the idea. This is someone who has resources, and
Yeah.
I have to say that that helps a lot with access. I do want to say. So, okay. She complains of headaches that are worsening with stress and seasonal allergies. Okay. I should also add, I live in Kansas City, Missouri. Allergies here are really, they're very prominent here, I have to say. So there's one
Okay.
condition that's very prominent in this area. So in any event, worsening stress, seasonal allergies, intermittent fatigue with snoring and daytime somnolence, and hot flushes, okay? She is taking 6 medications from 6 different physicians, okay? That she had, she's taking 6 medications from 6 different physicians she has irregularly seen in her previous locale, but she has not been seen and follow up by any of them for the past 4 months. And so, this is also a very common presentation where you have patients with multiple, it's not just, they come in with these nice, neat, they don't come in saying, I have diabetes, I have hypertension. They'll often come in with a list of symptoms. Some of them are clearly identifiable medical conditions, like when they say, snoring and daytime somnolence, you're thinking, okay, sleep apnea.
Yeah.
But, but oftentimes they're connected with other things like headaches. Okay, what are the headaches due to? Somnolent, or I should say, intermittent fatigue. Okay, I mean, maybe that's sleep apnea, maybe it's something else. So you'll also have constitutional symptoms that are included in the list of symptoms. And so there's some clear conditions that you suspect, but not always. You just have these constitutional symptoms that may be related to each other, maybe not, and that's part of the challenge, okay? And
Yeah.
that's something that you have to be comfortable with. So, and also you can get the idea of how the care can be just disjointed. So, we talked about patients with insurance. Sometimes they have insurance, then they go through periods without insurance. Sometimes they have an insurance and their doctors get switched. And there are lots of reasons why that someone may just go from one to another. Also, like we talked about in our last session, sometimes they get referred to specialists, so you have more physicians involved. Sometimes a patient, out of just patient satisfaction reasons, they say, well, I don't like this physician, I'm going to go to another. And there you go. So there are lots of reasons why you can have disjointed care like this, and that makes managing chronic medical conditions a challenge.
Trickier.
Yeah, exactly. So this, Mohammed, is kind of what you get. This is sort of the most common presentation, I would say, for a sort of a routine, routine family medicine practice. Yeah. So, okay. So, all right. Let me make sure we have all our info here. So, number one, given her symptom complex, at this time, she is likely to need the services of which of the following subspecialists? Is it A, a cardiologist, B, a psychiatrist, right? Because we know that behavioral health underlies a lot of what we see. C, a sleep specialist. Remember, we're kind of thinking sleep apnea. Or D, an endocrinologist. Or E, none of the above.
At this time, the best person to see her is us, right? Family physician, to go over her medications, try to fix her lifestyle first. Because she's obese, maybe the sleep apnea is getting worse because of her. Maybe if she lose weight, change her diet. She said,
Yeah. I mean, I agree, and it's interesting because this connects kind of with our previous session. When you're a family physician, it's sort of your job to kind of go into these different things and to address them as much as you can. And then if you're ready to send them to a specialist, you're sending them to a specific reason that only the specialist, or typically it's the specialist who's most ideally equipped to address, and usually with a specific question. So this is someone you would not want to just send to a specialist and say, here. Because if you send them to a cardiologist, then the cardiologist is going to refer them to these other specialists. So I absolutely agree. E sounds good. So let's go ahead and check the answer here. So it's E. You are a long way from consulting or referring to anyone, okay? Because we haven't done anything yet. You must first get a clear understanding of this patient's problems and how they interrelate. As the family physician, you are actually in the best position to do so, and it is your responsibility to do so. So there's pretty much the commentary on that. So you kind of get the idea now of how the family physician jumps in, to begin to address these things. Okay, some more information here. So on exam, the vital signs are blood pressure 150/85, pulse of 85, BMI of 30. She appears well developed, overnourished, and overnourished, I imagine they would, by someone who you know, consumes excessive calories, and well-spoken.
Overweight. Yeah.
Right, right,
Mhm.
exactly, exactly. And well-spoken, which, you know, might suggest that this person is educated, may have a may have a higher level of healthcare literacy, but not all patients are like that, okay? In fact, most of the patients I see are not like that. In fact,
Uh,
most of the patients I see do not speak English, actually. So
Whoa.
yeah, you know, when it comes to the demographics of the patient population I see, most of them are Hispanic, or in other words, they're Spanish speaking. Usually they're Spanish speaking only. So this adds another layer of, you know, communication, you know, challenges with our patients. So yeah, I mean, that's on top of, you know, and these patients will have multiple issues. And then, you know, I would say,
Yeah.
Mohammed, actually, that, you know, we know that about 80% of all health outcomes are determined by what we call social determinants. So that's something that we see here, or that we, you know, come to realize here in the United States, is that, you know, some patients do quite well. They have good outcomes. Some patients with the same conditions do not do as well. So there's a discrepancy in outcomes. And we see that the vast majority of the reason for this discrepancy lies in the social determinants. For example, one group is much more educated than another. One group has a significantly higher income than another. Probably they have insurance and the others don't. There might be some differences in lifestyle, but that can be tied to differences in access to the means of a healthy lifestyle. For example, we have what's called food deserts, where there are communities that do not have a grocery store nearby. They may have convenience stores, and convenience stores don't have nutritious food. They have processed
Yeah.
food. There are fast
Yeah.
food restaurants nearby, but there really isn't a good grocery store you know, with a lot of non-processed food options. Um, you know, sometimes some communities live in neighborhoods where you can't go out jogging, you know,
Mm.
you know, where you don't have a nice park to go to. Sometimes there's greater air pollution in some communities, or they may be living near certain utility facilities that may make their air or their water less, you know, less healthy or contaminated. There's a famous case. There's a famous case in Michigan, Flint, Michigan, where lead, the water supply of the community in Flint, Michigan, was exposed to high levels of lead, which had a major
Wow.
impact on the population, as you can imagine. So these are zip codes. So in the United States, different areas are sort of, you can identify them as different zip codes and the person's address. So some
Mhm.
zip codes have much more favorable social determinants than other zip codes, and so some zip codes then have better outcomes. So it's interesting in that you can actually identify if someone is more likely to have better outcomes based on where they live. So based
Mm.
on where they live, that can be a better indicator of their outcomes than maybe even their genetics in some cases. So, um,
Yeah.
so it's interesting, you know, when a patient is well spoken, then you say, okay, that might indicate some things about social determinants.
Yeah.
Okay, not always, certainly. I mean, not always, but you
For
get
sure.
the
Yeah.
idea of this overall, this person's an executive who has the means of traveling and things like that. So, okay, there
Yeah.
are, now continuing on with the exam, there are boggy nasal passages, nicotine staining of her buccal mucosa, clear lungs, and a normal sounding heart. Abdomen is obese. Skin is, it should say warm. Skin is warm and dry. Extremities are without clubbing, cyanosis, or edema. Peripheral pulses are normal and symmetrical. Affect is appropriate, okay, which is good. But Mood seems depressed. Okay. All right. So number 2. Now this is I think a very good family medicine question. So you just got done your exam. So you got your history, you got your exam. So now the question is, what laboratory data would you like to obtain at this time? Go ahead, Mohammed. What do you think? I'm just trying to see if Horam is reaching out or not. No, I don't see it.
Okay.
Yeah, okay. All right, anyways.
I might go and check C,
Okay.
CBC, metabolic panel,
All right.
lipids, and how old is she? She's
Question. Let's take a look. She is 55 years old. So good
yeah,
question.
for sure. So lipid profile.
Lipid, okay.
A1C to check her diabetes if it's under control.
Right.
And maybe we can check the TSH to see, because she's having warm skin, flushes.
Right. That's very reasonable. So we've got C. So we think a CBC, a CMP, lipid, A1C, EKG, TSH. That sounds very reasonable. Now, it may be, or it looks like the best answer for this question is actually, let me just double check. Let's see. It looks like, I thought I knew the best answer. I was gonna say E, actually. That's what I was gonna say. But my goodness, we got a different answer. So it's always nice to have the book with the answers, I guess. So it looks like the answer here is B, interestingly. So okay, let's see why. Number 1 was E. Let's just do that. Okay, so let's check out and see why. B, normally it would be best to get old records before obtaining laboratory tests, particularly if the situation is not urgent. That's sort of what that's what I was thinking the answer was going to be. I was thinking, to be honest, that the question was getting at, we want to, minimize repeating unnecessary laboratory tests, especially if she's had it before. That's sort of what I was thinking of, but it looks like that's not correct. So
I think maybe not, because
yeah, go ahead.
She didn't see a doctor for 4 months, so I thought maybe she need in the first question they said she didn't see a provider for 4 months.
That's right. 4 months, exactly. So that's required. That's a little bit of time, so it's true. So
yeah,
let's see. So normally it's a good idea to get some old records before obtaining laboratory tests, particularly if the situation is not urgent. However, in the case of the previously fractured care experienced by this patient and the time since the last visit, to your point, Mohammed, and the time since the last visit to all the subspecialists, the likelihood of receiving information in a timely manner in the absence of a shared electronic record is limited. Therefore, obtaining baseline information in this patient's situation is most appropriate. Okay. So I think, so it sounds like if you happen to have the results and if you share the same electronic health record, great. Otherwise, it's interesting because this question is acknowledging the reality. Because I thought the answer was E, but it's true. In reality, I would probably get labs in reality. There's more to this answer, because let's see why they selected B in particular. Of the combinations listed, that of the CBC, CMP, lipid profile, A1C, and ECG is most reasonable to cover this patient's multiple morbidities listed in the history. Interesting. So they actually did not put TSH in there. Yeah, interesting. Well, Mohammed, I'll share with you what I usually get. So in practice, what I usually get is something called routine health maintenance labs. So this is like,
Okay.
for example, in a situation like this, and I'll tell you what I get. Okay, I'll tell you what I get. What I get. So, um, um, well, no, let me take that off. Actually, I mean, I can just say it, I guess. But what I get is I usually get an A1C. I usually get a lipid panel. Now, the reason why, now, after, when I get a lipid panel, I usually get a CMP with the lipid panel
Okay.
myself. Now, the specific reason why is because, let's say with the lipid panel, I need to start a statin, let's say. And if I start a
Okay.
statin, then I want to, I need the patient's baseline liver function.
Yes,
Because,
exactly.
yeah. So that's why if I get a lipid, I will automatically get a CMP. Okay. Now, could
Hmm.
I get liver function testing? Yeah, I could. I suppose I could. Um, I suppose I could. I guess it's just in practice, I found it to where I get the CMP. Now, the thing is, this patient has an elevated blood pressure, right? So many patients will have blood pressure problems. So if they have blood pressure problems, then for that reason, I find it beneficial to include renal function, okay? And
Hmm.
also electrolytes in case I need to start an antihypertensive. So a lot of times for this reason, just as a standard panel, if I get a lipid, I'm usually getting a CMP as well. And maybe I don't start an antihypertensive agent right away, maybe it's later, but it's good to have that, it's good to have that baseline information. And also, if
Yeah.
the patient has multiple issues and a lot of constitutional symptoms, it's good to make sure there are no electrolyte aberrations. It's good to make sure that the liver and kidneys are functioning normally. So anyway, but specifically, if I get a lipid, I will usually get a CMP along with it because of the transaminases at least, and because just in general with the
Hmm.
patients that we see, the rest of the CMP is helpful as well. So that's why I will get a CMP. Um, Now, if I get an A1C, usually I'm getting a lipid with it, by the way. Why is that?
Right.
Let's say a patient has diabetes. Well, if a patient has diabetes, then by our guidelines, we automatically need to start them on a statin, automatically. So
Hmm.
if now, in order to determine the correct statin regimen, does it need to be a moderate intensity statin or a high intensity statin? In order to know what regimen of statin I need, then I need the lipid panel. So if I'm getting an A1C, I'm usually getting a lipid panel with it. You know, if the patient
Yeah.
has diabetes, if the patient is, if we see if the patient has diabetes, or if the patient is known to have diabetes, either or. So if I get an A1C, usually I'm getting a lipid. If I'm getting a lipid, usually I'm getting a CMP. Okay. All right.
Mhm.
Now, um, this is kind of where I deviate a little bit from this answer in practice, to be honest. And who knows, maybe I need to update my practice. That's entirely possible. But normally when I get a lipid, not only do I get a CMP, but just something I was trained in residency is I usually get a TSH with it. So why is that?
Mhm.
Well, my particular attending um, suggested to me that when you get a lipid, it may be that your triglycerides may be very elevated. And if your triglycerides are elevated, you may want to rule out hypothyroidism as a cause for the elevated triglycerides. So,
That's true.
so I mean, yeah. So for that reason, if I get a lipid, usually I will get a TSH as well, and that's why, Mohammed, I kind of agree with you. If I had to pick one, I would probably pick C. Actually, if I had to pick one, but you know, and it looks like it wasn't the case in this particular answer. Now, it's interesting in that the CBC, I will be honest, I do not routinely get a CBC unless the patient has a known cardiovascular disease, or something like history of anemia, or something where, clearly a blood count is needed.
Yeah.
However, having said that, when I have patients with constitutional symptoms, okay, and it may include fatigue, then a CBC certainly is important,
Yeah.
right? Because the patient may be anemic, all right?
Anemia. Yeah.
So therefore, a CBC is important. Now, having said that, usually when a patient has constitutional symptoms, which include fatigue, I'll usually get a TSH with that as well, actually. So in my
Yeah.
mind, when I look at the case, now certainly the fatigue, does it really sound like sleep apnea? Yes, it does. Yeah, I mean, but hot flushes, you can make the argument that a TSH can be helpful there. Although hot flushes in a 55-year-old woman, you're
Yeah.
thinking, I mean,
Menopause.
in
Maybe.
all likelihood, she's postmenopausal, right? Or
Yeah.
peri/postmenopausal. So, I mean, that's probably the reason there.
Mm-hmm.
So in practice, though, some of these symptoms, especially if this initial presentation, you have this list, it's not quite clear how they're related necessarily. A lot of times I'll get a TSH with it. So I'll get a TSH in the setting of fatigue, in the setting of mood disorders, and I will get it if I order a lipid panel. So those are the times where I will oftentimes get a TSH. And like I said, if
Yeah.
they're complaining of fatigue, usually I get a CBC and TSH. So for me, I don't routinely, as part of routine health maintenance labs, while I certainly can see how it's appropriate in this patient, if the patient has no symptoms and they're just middle-aged, I'm getting routine labs, a lot of times I will not get a CBC. So, and then the last thing is an EKG. And an EKG may be something possibly that's overlooked in many practices. So if a patient has hypertension, or some sort of cardiovascular disease such as hypertension, then it's reasonable to get a baseline EKG. That's a good thing to do. So in fact, at my organization, we're looking to start a hypertension clinic, and we are looking to make a baseline EKG as a standard part of that hypertension clinic. So an EKG to me certainly is important, but I don't see in the answers why it doesn't specifically talk about why not getting a TSH.
But
Yeah.
a quick question about you. We talked about checking A1C, hemoglobin, and you said lipid profile to decide if it's low, moderate dose or high dose statin.
Yeah.
Don't we give high dose if they are only below 75, or there's other requirements to give high dose or moderate?
Well, to my knowledge, high dose statin comes into play if you are a diabetic and you have an estimated risk of cardiovascular disease in the next 10 years of at least 7.5%.
Yeah.
If it's 7.5% or more, then that, and in the setting of diabetes, that is an indication for a high intensity statin. By the way, that 7.5% can be lowered to 5% depending on the presence of other risk factors. So let's say a patient has a very strong family history, or if they have, an autoimmune condition, or other risk factors, that risk can be low, that threshold can be lowered to 5%. But in any event, they meet a certain threshold for risk of cardiovascular disease in the next 10 years, and they have diabetes, that is an indication for a high intensity statin. If the patient has established cardiovascular disease, so they have established coronary artery disease, or they have had a myocardial infarction of some type, or they have had a stroke or TIA, and a neurologist may just tell us a TIA is a stroke. But if they have end organ evidence of cardiovascular disease, then that is, or I should say, if they have established cardiovascular disease, then that is an indication for a high intensity statin as well.
Yeah.
Yeah.
We only give moderate dose if they are above 75 years old. In those cases, you
Oh,
mentioned.
above 75. Right. Yeah. I mean, right. So that's yeah, the elderly population. So that's good to know. That's good to know, actually. So for yourself, Mohammed, if they're over 75, that's the, if I understand right, that's the only time you give moderate intensity?
I think so, yeah.
Oh, okay. So you give high intensity.
Just for side effects of statin, because of the side
Right.
effects of statin.
Got it.
Yeah.
Got it. Okay. So everybody under the age of 75, you give high intensity.
And yeah, if they
Got it.
have what we just mentioned, like diabetes and peripheral artery disease,
I see. I
so
see.
on.
Yeah, exactly. Peripheral vascular disease, that's clear cut high intensity. So okay, got it.
Okay.
So okay. So why no TSH? I don't know. Can't tell you. Can't tell you. So I guess that maybe that's something that we might need to read up on is you know, I mean, I will say that you know, to do like an annual screening with the TSH. Let me actually see, Mohammed. Now I'm curious. Let me check on guidelines for thyroid screening. Let me double check that. I'm curious now. Let's see if I can find it. USPSTF thyroid screening. Let's see what it says. Recommendation for thyroid dysfunction screening. Oh, very interesting. Non-pregnant.
There's no screening, right? Or there is?
Well, here's the thing. Let me see. Bear with me, Mohammed. I'm going to see actually if I can put this on the screen. Bear with me. Here we go. Hold on. I'm almost there. Copy. Let's see if I can. All right. Okay, so I don't know if you'll be able to see this, but
Yeah, I can see it.
okay. So, right. Okay. So basically the USPSTF, which is what regulates all or not regulates, sorry, I'm a little under the weather today, so bear with me. But it provides evidence-based guidelines on screenings. It states that the current evidence is insufficient to assess the balance of benefits and harms of screening for thyroid dysfunction in non-pregnant asymptomatic adults. There are some special considerations which we can read up on. Let's see. And then like the available evidence showed a lack of new evidence to support an updated systematic review on the topic at this time. Okay, sounds good. So it's insufficient to recommend for or against. So it's up to you. It's up to you. So if we did get a TSH,
I know about this USPSTF because I had it for my CK, and yeah, I remember they said if for non-pregnant, besides pregnant women, you shouldn't screen unless you have symptoms.
Right.
But here in our case, we thought TSH is related to her lipids, to her depression, to her some signs of fatigue and one.
You're absolutely right. You're absolutely right, Mohammed. I think in practice, if it were me, I would get a TSH as well. She has depressed mood after all. And the other thing too is you're already poking her with a needle. So what are the, there's the risk of poking her again with a needle later. So sometimes it's better to poke someone with a needle once compared to multiple times. So that's sometimes something that comes up in my mind as well. So, But yeah, good job, Mohammed. I'm proud of you. You knew this recommendation already. That's very good. So,
Thank you. Yeah.
okay. Okay, well, at least we know what the answer is. So let's move on to our next one. Okay, results from the medical outcome study suggest which of the following is or are true regarding systems of care for this patient. Why don't you read that, Mohammed? I'm going to plug my computer, okay? I'll be right back.
Sure. Okay, results from the medical outcomes study suggest which of the following is or are true regarding systems of care for this patient. Optimal clinical outcome. Okay, let me. Best achieved when care is provided by generalist. Optimum clinical outcomes are best achieved when care is provided by subspecialists. Cost of care and resource use tend to be lower when care is provided by generalists. Similar clinical outcomes are achieved when care is provided by either general or subspecialist. Do you want me to read the abstract?
Oh, no, Mohammed, I wouldn't ask you to do that. This is the abstract from this medical outcome study. It looks like it was published in the Journal of the American Medical Association all the way back in 1989, so over 30 years ago. All right, sir, what do you think? What do you think is the answer here?
C is right.
Okay. So you like C?
Yeah.
Okay, let me take a look at it as well. So optimal clinical outcomes are best achieved when care is provided by a generalist. Sounds appealing. We are talking, we are talking about family physicians after all. So let me put a pin in that. B, optimum, should say, let's say optimal, or that's fine. Optimum clinical outcomes, no, it should say optimal. Optimal clinical outcomes are best achieved when care is provided by subspecialists. That's a suspect comment, probably not. Costs of care and resource use tend to be lower when care is provided by generalists. Absolutely, absolutely. So that is clear.
Yeah.
We don't apply the same expensive tools that a subspecialist may on a routine, regular basis. So that sounds appealing. So A sounds appealing. C sounds appealing. D, similar clinical outcomes are achieved when care is provided by either a generalist or a specialist, or subspecialists. So, well, it seems that B and D are B, C, and D are kind of opposite. So C and D are sort of opposite. It says cost, well, C is cost of care. C is cost of care. And then similar clinical outcomes. Well, D, I guess D and A are opposites. Or they're
A and B.
What's that now?
A and B are opposites.
Right.
And I prefer C because A might be true, as you said, but maybe the optimal is both of them, generalist and if needed a subspecialist. Maybe that's what they are tricking us into. But C for sure, cost of care is always lower when we actually intervene instead of sending to a subspecialist.
Yeah. Without reading the abstract here, I don't even think really gives us the answer. But I'm really attracted to to indicate how outcomes are better. But what we know, like you were saying, Mohammed, cost of care tends to be lower. So I guess which one is more true? I'll agree with you. C sounds good. So ready for the answer?
Yeah, let's see.
Number 3 is E.
Oh my God. So C is right,
So
but
C
C
is
as
right,
well
but I
C.
guess so is D. Similar clinical outcomes. Interesting. Okay, well, let's take a look then. Let's take a look. All right. So, and I guess even without looking at the answer, so we know D is right then. I mean, that's what it's telling us. So, I guess it's important to have so yeah, I mean, I guess what it's saying is that it's the outcomes are not of a family physician are not inferior, so it's not inferior to a subspecialist, and the cost is lower. So the outcomes are the same, and that's very important. If a patient has different cardiovascular conditions, it doesn't mean you have to see a cardiologist. You can see your family physician, and the costs tend to be lower. So that's why it's more beneficial to see the family physician
Yeah.
at the outset. And then the family physician can loop in the subspecialists when needed. So maybe that's what it's
Mhm.
trying to say. Let's take a look here. All right, here we are. So this is what? Number 3. The medical outcome study is the classic, well-designed, comprehensive study that compared outcomes of care by generalists and subspecialists after controlling for the patient's mix. Reported in the Journal of the American Medical Association and other medical journals, the comprehensive study found no difference in outcomes between generalists and subspecialists for patients with diabetes and hypertension who were observed for 7 years. Outcomes included measures of physical and emotional or functional health, mortality, and disease-specific physiologic markers, I'm assuming like an A1C. However, there were significant differences with regard to lower resource use and cost for patients for primary care physicians because of more judicious use of tests, procedures, drugs, office visits, and hospitalizations. So that was it.
Okay. Yeah.
Yeah.
Makes sense.
Makes sense. Yeah.
Yeah.
So we're going to do the more routine tests. We're going to we're going to do the treatment interventions that are indicated prior to a procedure. We're usually going to prescribe the cheaper medication options first. We're not going to prescribe the super expensive chemotherapeutic drugs at the outset. The family physician is based in the office, whereas other specialties, really, they may see patients in the office, but really where they do their practice is in the hospital. So,
Yeah.
our setting is a lower cost setting, even before you even before considering the practice. So,
Yeah.
yeah, makes sense. Okay, Mohammed, we learned something.
Yeah.
I was thinking I was biased clearly in this question. By the way, as
Yeah.
a disclaimer, I have passed all my boards. It may not seem like it, but I have. I passed all my
No, not
boards.
at all. These questions are nice.
So actually, this is good practice for the next time I take the board. So don't want you to think, don't
Oh,
want you to,
you have to take it again in how many years?
oh yeah. We, in family medicine, we take it every 10 years.
Oh, okay. Okay, understand. Yeah.
Actually, that's a very interesting topic, even a whole topic by itself, Mohammed. It's very interesting. It's called maintenance of certification here in the United States. So that's board certification, and that's different from licensure. But to be board, and it's important to be
Mm.
board certified. And yes, there's been a lot of sort of reforms and updates to the process of being certified. How often you take your tests, what other requirements are there, things like that. So
Mhm.
yeah, I
Okay.
think I'm due again in 2024, I think. Something I think.
Oh,
Okay.
okay. Still some time.
All right, moving on. Let's see here. Okay, this case points out that which of the following is or among the skills needed to manage patients with multiple morbidities. Let me just say, Mohammed, something that I will see at my organization sometimes is I may have junior colleagues who may say, oh, but Dr. Murad, when a patient comes and they have many things going on, what do I do? And for me, it's like, well, that's something we can definitely talk about, but this is part of family medicine. This is it, especially if we're talking about patients who don't have insurance, who have not seen the doctor in some time, then most definitely there will be multiple things going on. So it's something to expect. So if someone goes into family medicine, it's not something they should really complain about, that, oh my goodness, my patient has more than many things, what do I do? This is not right. It's like, no, that is right. That's how it is. So so when we talk about the skills needed, that's kind of part of it. That's why a family physician, it's not just liking broad spectrum of practice, but this is an important sort of management skill almost. So, because you're managing the patient's care.
Yeah.
Okay, Mohammed, let's see. So, is it A, the capacity to thrive on managing complex medical problems? Is it B, the ability to integrate all of the medical and personal issues facing an individual? C, the ability to break down medical terms and complex medical issues to make it easier for patients to understand? D, the capacity to know and understand an individual's limitations, problems, and personal beliefs when deciding on treatment? Or is it E, all of the above?
E, all of the above.
I would agree with you. I would select E as well. And it's interesting. It says the capacity to thrive. I mean, people need to get a lot of professional gratification when you do a good job seeing a patient and managing their issues, and then you see them for follow-up and you're continuing to manage all the issues and make progress on those issues, to get professional satisfaction from saying, oh, wow, I am successfully managing all these conditions. That's important in a family physician. If someone says, I really hate this, I can't stand this, I
it's not for them.
It's not for them. Now, don't get me wrong. Is it tiring? Yes, it can be tiring. Can it be exhausting?
But that's part of any job.
Right. Can it even lead to burnout? It can. And that's something else that we can always talk about. That's why it's important to have a good system in the office, a good system that supports you to see the patients. And another thing is that's why my personal sort of preference, my personal suggestion to students is that if you do family medicine, it's a good idea to have another interest as well. So for example, I focus on obstetrics and women's health. That is my area of interest within family medicine. And I get gratification from that, from being able to focus in one area and also to be able to manage multiple medical problems. In fact, I find that they complement each other. If you have a specific interest, that helps you actually in in managing other conditions, because your depth of knowledge tends to be a little bit deeper when you have a special interest. So it helps you when you're managing multiple medical problems, and also when you are seeing that specialized case, like if they come in just for a prenatal care or women's health. But then, of course, they have many issues they like to bring up too. So being broad supports you in that situation as well. So I find it very gratifying. But the point is that, you need to be able to, if someone says, I just hate tolerating multiple. Was that Mohammed? Sorry?
Yeah, you're right. You have to have it all. And not specifically that this, you have to be ready for all these multiple comorbidities showing up in one patient.
Yeah. Yeah, exactly. And at some point, I can share with you how I like to prepare for clinic. So when you see a patient with multiple medical problems, it's a good idea to prepare for clinic in a certain way. So just remind me at some point and we can talk about that. So B, the
Yeah,
ability to, and then to integrate all the medical and personal issues. So yeah, I feel like B and D, I feel like they're talking about, you know, you kind of know the patient too, you
yeah,
know kind of about their background, you know about, you know, what stresses them out, what they're able to do financially. Can they afford certain things? Where do they live? Are they able to drive to a certain place to see a specialist? You know things about patients. Like,
yeah.
oh my gosh, this person is totally not going to be able to comply with this regimen. That's for sure. Like, simple example, a 17-year-old giving them birth control pills. Are they going to take it every day? No. If you know them reasonably well, you'd
Probably
say, well, they
the
may not.
compliance will be, yeah.
Yeah.
This
So
is
anyway,
why I love family medicine. Yeah, you gotta connect with your patient, know about what makes him feel bad, what's hard for him, what's easy for him,
right.
what he wants to improve or she, you know. So
Right. That's another good point too, because it's what is the patient's priority? You know,
yeah,
what are they focused on? So yeah, I mean that's definitely. And I was going to say one other thing. Anyway, I think you said it better. I think you said it better. So, um, and then oh yeah, and then C I think talks about communication with the patient, like you know, like to explain things. I mean, that's part of our job too. I actually enjoy this part, actually. I like wording things in a certain way.
mhm,
And it's interesting because nowadays we'll respond to patients by text message and through the patient's portal, that they can access through their email. So a lot of the communication is written. So to explain their
yeah,
lab results, for example, like here's your result, and you're trying to explain what it is. And of course, sometimes you have results that are abnormal but not really remarkable, and you
mhm,
have
yeah,
different nuances in the results. But to explain it in a way that makes sense to the patient, that's relevant to the patient, I actually enjoy wording things in certain ways. When
yeah. This
consent,
happened to me a lot of time.
yeah, go
So
ahead.
this happened to me a couple of times when some of my family members they send me some lab results, and I mean, when they point out there's something wrong here, they put like a small star next to it, and
Yeah,
they panic about it.
right,
And I have to explain that not every time it's significantly high or significantly low. You know,
right.
yeah,
Absolutely. You're exactly right. That's exactly what patients do. And
yeah,
even before like a procedure, you have to consent to the patient prior to a procedure, which means what? You need to explain
yeah,
the
yeah.
risks, the benefits, and how you do it,
Hmm.
the alternatives. So to explain that, it's kind of fun, actually. You sort of
Yeah,
like when you explain the benefits, you explain it in a way that is something that in particular, I love. My favorite consent process is for colposcopies. That's my favorite one, because
oh really?
colposcopies, yeah, yeah, because colposcopies, it's to, as you know, it's to follow up on an abnormal pap smear. You take just
Yes.
a small cervical biopsy or a few, and you confirm what the cervical pathology is. But I love it
Mhm.
because the patients, when they come in for a colposcopy, they're always so anxious. They're so anxious, and so the goal of my consent process, clearly, if they're anxious, I better be talking in understandable terms. you know,
Yeah,
I
yeah,
better
yeah,
be
yeah.
understandable, or else they're not going to. But also, you're talking about preventing cervical cancer, and
Mm.
you see kind of what works for you, and for what works for me is I see how to talk about cervical cancer. And so if I were to say that, okay, this is to make sure that you don't have cervical cancer. Oh my gosh, my experience is that does not decrease their anxiety. Okay. So I learned how to say it in a certain way that that reassures them this is not something you necessarily have now, but we want to prevent this from you. We want to prevent you from getting this in the future. the words that I use, do I say the word biopsy? Do I say the word cancer? Do I say the word procedure? When do I say those words and how? So how you use your words and using words that the patient understands, words
Mm.
that some words have certain connotations and meanings, other words have other connotations and meanings. So anyway, I find that because you're talking about cancer, you're talking about things that possibly are, potentially are related to lifestyle choices. You're talking about, a procedure that can be painful,
Yeah, exactly.
all these things, and you're talking about like infectious disease, all these things kind of come together, and it's my favorite one because I find that that's the most practice of talking to a patient in a way they can understand, that kind of keeps all those things in mind. So anyways.
Really, thank you because you do this. My aunt recently was diagnosed with breast cancer. She's
Oh.
in Michigan, in Dearborn, by the way.
Oh
Uh,
really? Yeah.
yeah, yeah.
Wow.
She's not good in English much, so there was a translating with her in the office, and the doctor, I don't know if she did a good job or not, but from her reaction, she was extremely scared. She was crying. She called me directly. She didn't want to tell anyone.
Oh
And
wow.
even before the biopsy, she was mentioning cancer a lot. And for her, she's not good in English, but she definitely know what cancer is.
Right.
So she was hearing all the time cancer, cancer in her head. She
Right.
left and she was panicking, crying. Um, yeah.
Yeah, it can be very hard, very hard. Did she end up going
Yeah.
back? Did she resume?
Unfortunate. I mean, I don't know if I should, fortunately or unfortunately. At that time, what the doctor was investigating, it was just a cyst in
Oh,
her axilla region,
oh, okay.
which we are thankful, but they took a biopsy of the lymph nodes as well, and that's when they found out metastasized breast cancer. So
Oh,
this cyst
wow.
actually saved her. Yeah, they caught it
Wow.
super early on.
Oh,
Thank God.
good, good.
Yeah.
Absolutely. Wow. Oh, I'm so glad that, that was caught. So how's
Yeah.
she doing now?
She's doing great now. She's
Yeah.
getting used to. She did a small maybe 5 to 7 chemo sessions. Uh, she didn't need any surgery,
Good.
and yeah,
Wonderful. Excellent. Well,
thank
I'm
God.
glad. I'm
Yeah,
glad, Mohammed. Yeah. Yeah, you see how communication is such a big part of things. By the way,
yeah, yeah.
my sister's a surgery resident in Michigan, actually. So,
Wow. In which hospital?
she's in the Henry Ford system.
Nice. Yeah, yeah. Most
Yeah.
known, I guess. There.
Yeah, yeah, yeah. So pretty close to where your aunt lives, I think. It was your aunt, right?
Mhm. Yes, aunt.
Yeah, yeah, probably pretty close to where she lives, I imagine. So, well, good. All right, Mohammed. Well, let's look at the answer, shall we? Number
Yeah,
4.
sure. Let's
So
do it.
answer is okay. Well, not surprisingly, we were correct. E.
Yeah.
So basically, and I think, we already talked about it, I think. I don't know if we need to. Let me just see if there's any other information they mentioned. Multiple skills are needed to manage patients with multiple morbidities. These include the capacity to thrive on managing complex medical problems, which we know, the ability to integrate all of the medical and personal issues facing an individual, okay, we know, the ability to break down medical terms and complex medical issues to make it easier for patients to understand, okay, talked about that. The capacity to develop long-term healing relationships with patients, and that's important as well. The capacity to know and understand people's limitations, problems, and personal beliefs when deciding on a treatment. The ability to provide care that includes long-term behavioral change interventions that lead to better health. The ability to empower patients with information and guidance that are needed to maintain health. The ability to link patients to appropriate community resources. And finally, the ability to mobilize and facilitate proper use of and communication among those resources. The family physician, by virtue of his or her training, is uniquely positioned to deliver these skills to patients with multiple morbidities. Okay, so
Mm.
pretty much what we said. I find too,
Doctor, sorry to
yeah, please.
interrupt you,
Sure.
but just now it came to my mind. I checked
Yeah,
my email,
yeah,
and the invitation was sent to me. Did you send it separately to Forum?
I did. Yeah, I sent it to
Okay,
Forum. Let me just double
okay.
check here.
Yeah, I just
It went to, let me double check now that you mention it.
okay.
Let me see. I hope so. I should give him my phone number, honestly. Let's see. Let me double check here. Give me one moment. Pretty sure I did. Pretty sure I did.
Okay. Okay.
Yeah.
So maybe he had something.
I don't know. Let's see. I'm pretty sure it got sent to him. So yeah, maybe something came up. Let me see if he has a phone number, actually. Yeah, I'm not seeing it right away. So, okay. Yeah, maybe something came up. Alrighty. Well, let's keep going. So, in addition to reviewing all her medications, obtaining any previous medical records you can, and ordering some laboratory data, your next step in management should include which of the following? Is it A, assessing the patient's understanding of her health problems, B, getting a sense of the patient's priorities in dealing with her health problems, C, reordering all her medications and stressing the importance of compliance, or D, identifying community resources that can be brought to bear in a treatment plan? Or is it E, A, B, and D? What do you think?
Um, B is right.
Yeah, I would agree.
Prior assessing the patient for health problems. A can be two. So maybe E. Medical
Yeah,
community research can be brought to
I
bear.
you like E?
I like E. Yeah.
Okay, okay. All right. So, I do as well. Now let's see what the answer is. Oh, hang on. I want to make sure I don't make an error here. Your screen sharing is paused. You can see my screen, correct,
I
Mohammed?
can.
Okay,
I can.
perfect. Okay. Hoping that I didn't make an error here. Okay, so I would agree with you, E. Now, I will tell you, you know, there's one specific patient I recall that reminds me of C. It was a patient that came from the West Coast. I think she lived in like the Seattle area. She
Mm-hmm.
came from the West Coast, and then she came to this area where I'm at, and she came with many, many medications, and she had seen multiple providers in the past. And normally you would say, okay, let's reorder some of these medications. Some of them seem like duplicates, actually. And
Okay.
one thing I regret with this patient is not being more active in revamping her medication list, because they really, to me, did not, I wouldn't be a combination that I would prescribe, yet the patient was very emphatic that this was her medication list, and
Mm.
that this is what works for her. And and maybe it even wasn't so much that, but she says, oh, I saw this doctor, and she would name the doctor by name, even though they're in a different part of the country. Say, oh, I talked with this doctor, as in, oh, I talked with this, I was at this prestigious institution here, and I talked with this doctor, and they prescribed this, and they talked with this doctor and prescribed for me this. And I think at the time it was like, oh, well, okay, it sounds like you really want to stay on this, basically. And it I think what I needed to do a better job of was to take a more active role in saying, you know what, let's take a look at these. Okay,
Mhm.
especially she comes in with a laundry list of issues. So that's something I should have done, as opposed to maybe doing what it says in C. It says, let's just give you all the same meds and just make sure you take them. It should have been maybe reorder the same meds, but by the same token to say, we may need to take another look at this. It's possible we may not need all these medications, something like that. So
Yeah.
this really reminds me of how I could have been a better family physician in one particular situation. Okay, the answer is
Okay.
we're doing good. See, Mohammed, you can pass your family medicine boards if you come here. So
One day, yes.
the answer is E. So it says here, without a clear knowledge of the patient's understanding of her medical conditions or an assessment of the patient's priorities in dealing with her health problems, reordering all her medications is likely to be a wasted opportunity to identify and prioritize the patient's needs and conditions.
Yeah.
Without this information, stressing the importance of compliance is a waste of time.
Mhm.
This is also an opportunity to identify community resources that can be brought to bear in a treatment plan. Okay, so that's really what this is an opportunity for. It's to, is to really identify and prioritize the patient's needs, basically. So, yeah, I think that yeah, I think it's just as family physicians, sometimes I think there's a trap where it's just easier. It's easier, and especially we're
Yeah.
oftentimes stressed for time.
Time.
So-
Yeah.
Exactly. So it can be sometimes it's just easier to say, here, here's all your meds. We'll just keep going with these meds. But maybe you do that initially, but I think, there needs to be a more active role in saying, okay, let's work through these.
Mm.
And that's where a supportive office helps as well.
Yeah. This was really stressed in my geriatrics course.
Yes,
Going through the medications is extremely important,
yes,
and going through the side effects of each medication. Maybe that's why this patient is presenting to you with, I don't know, certain presentation.
exactly. And I think
Mm.
with this, it reminds me, I think with this particular patient, instead of saying, oh, okay, you feel this way, you feel that way. Well, maybe let's see what diagnosis it is. Well, it may
Yeah.
have been a better idea to say, let's maybe take a closer look at your medication list. Let's make it a more appropriate list. Let me try and convince you, of what I think would be good. And maybe you'll feel better and you won't have a
Yeah.
whole laundry list of issues. Yeah,
Yeah.
that as a family
Without
physician,
ordering more.
yeah,
Mm-hmm.
exactly. So, all right, moving on. You decide to enter your patient in your office-based disease registry. Which of the following is or are true regarding disease registries? Is it A, they are a useful way for tracking practice adoption of disease and patient-centered guidelines? B, they require the use of an electronic medical record? C, they can facilitate population-based interventions such as hemoglobin A1C tracking or influenza immunizations? Is it D, both A and C? Or is it E, they are primarily a research tool of little use clinically? What would you say?
I think I'm not sure what disease registry is.
Okay, so a disease registry is sort of like, you can think of it as a list of patients that have a certain diagnosis. So all the patients with diabetes, all the patients with hypertension, and so forth.
Okay, so maybe D. They require this.
A and C, yeah, I think that certainly sounds attractive.
Because they are pointing out on
Mhm.
like the guidelines for all population and disease and patient-centered guidelines. Yeah,
Right, right. Let me
population-based
see. Let
intervention.
me see, Mohammed, if I agree with you. They are a
Okay.
useful way of tracking practice adoption of now. So I think with registries, true too, you're able to, you keep track of, like, if let's say it's a patient with a list of patients with hypertension, you can see if their most recent blood pressure is controlled. So I think it's a use of tracking, you know, you can gauge if you're tracking guidelines, or you can gauge if the practice has adopted guidelines, I think. They require the use of an electronic medical record. That is no, I don't believe so. I don't believe so anyway. Oh, wait, I think it's Horam.
Yeah.
See, I told you, Mohammed. I told you I sent it to him.
Good morning, Doc.
Hey, Horam, how's it going?
I'm doing well, doctor. Sorry about this. I did get it a little bit later than expected.
Absolutely, Horam. Don't worry about it. I think this was my responsibility to make sure that you had it in sufficient time. So
I'm sorry. Yes.
don't worry about it. No, it's I realized that I actually did not send these slides as I as I was as I was
Yeah.
as I said I was going to do. So I do very much apologize for that. But good news, Horam. Um, because we are recording these and uploading them to YouTube, you can actually catch the first part of it.
Awesome.
Yeah. So don't worry.
Sure.
So we're glad you made it. Actually,
Yes.
Mohammed was very worried about you. He was like,
Thank you for your awareness,
yeah,
Mohammed.
he was.
I
He
made
was
it.
very
All right.
concerned. He was like, "Did you send him the email?" I said, "I swear, I did." You know, so. All right. Well, actually, Horam, this is a very good spot to jump in. So, so you decide to enter your patient. Well, and let me back up and say that, you know, our topic is managing multiple medical morbidities in family medicine. And the first series of questions had to do with, you know, what are the skills a family physician needs to manage multiple issues? You know, what are some reasonable baseline labs to order in a patient who presents with multiple medical issues? You know, and it sort of dovetails a little bit with last time about interfacing with specialists or subspecialists. So those were some of the things that we covered. So feel free to, you know, just check out the YouTube clip, and
Yep.
hopefully, so I never uploaded anything to YouTube before until last week. So I actually got it. So I'm gonna try, after we get done, I'm gonna try and do it again. Hopefully I'll you know, I can do it. So just check that out.
Awesome.
And actually, Horam, we are now transitioning to a part of, when it comes to this topic, we're transitioning to the part that deals with the office itself. Like, as a practice, how does not just the family physician anymore, but how does a practice or an office approach managing multiple morbidities? So, so actually, Horam, this is number 6 that we're on. So we can we'll read it again for your benefit, and let's see what you think. So you decide to enter your patient in your office-based disease registry. which of the following is or are true regarding disease registries? Is it A, they are a useful way for tracking practice adoption of disease and patient-centered guidelines? B, they require the use of an electronic medical record? C, they can facilitate population-based interventions such as hemoglobin A1C tracking or influenza immunizations? Is it D, A and C? Or is it E, they are primarily a research tool of little use clinically? What would you say?
Hmm. Would it be A and C?
You know, I would agree with you guys. Let's see what the answer is. So the answer is yes, A and C. All right. So basically, when we review the answer information here, so and so yeah, I was basically gonna, before we look at that, I was basically gonna say that, you know, sometimes practices, because it's always encouraged, like you should have disease registries, like you should be able to pick a diagnosis. And
Yeah.
by registry, actually, Mohammed was asking earlier, what do you mean by registry? So basically, you pick a diagnosis and you get a list of all patients with that diagnosis. So a lot of times practices, you know, they'll say, well, I don't have an electronic health record, although that's very few and far in between nowadays. But someone say, I don't have an electronic health record. You actually don't need one to have a registry. So that's, you know, that's something to keep in mind. I mean, heck, even an Excel spreadsheet that's, you know, protected, you know, not shared and so forth would be fine. But let's see what the answer info is here. So disease registries are a useful way for tracking practice adoption of disease and patient-centered guidelines. It is a common misunderstanding that to have a disease registry, you need an electronic medical record. This is not the case. Registries can facilitate population-based interventions, such as hemoglobin A1C tracking or influenza immunizations, as well as facilitate and track other patient-centered interventions. Although some have been used in practice-based research, their primary application is clinical care. So you can publish a lot of stuff from this, but primarily it's clinical care. And in fact, what I would like to do with you gentlemen is I would like to share the online platform that keeps track of the disease registries at my organization. So if you bear with me, I will share that now. I think you'll like it. Let me bear with me here. And in fact, what I will do, I'm going to stop share here. I'm going to share this one. Let's see. There we go. Can you guys see it?
Yes.
This is an online platform that keeps track of our quality measures, and it does so by automatically maintaining a disease registry for our patients. So let's go to, we were talking about A1C, right? So this is my organization. So in my organization, these are our quality measures.
A lot of depression screening.
A lot of depression screening, yeah. These are all the quality measures that we are responsible for keeping track of and improving. So let's look at diabetes. Actually, I don't like diabetes because it's kind of weird. That's okay. That's fine. Let's look at it. This measure is interesting because the lower the measure, the better.
Yes.
So basically here's our organization in ranking with other organizations. And as you can see, we have a lot of improvements left to do. Now, so we're able actually to compare ourselves to other organizations that are similar to us in the state of Kansas, where our organization is. And here we're able to look at our quality measure over time. And then if we want a list of patients, we can get that here. Well, let me stop share before I share some patient information. I don't want to get in trouble. So hold on. let me get out of that. Well, suffice it to say, let me go back to it now. That was close, we don't want to share patient info, but so if I go to detail list right here, I get a list of patients.
Mm.
And that's all the patients that have this diagnosis. And then we can see which patients are controlled and which patients are uncontrolled. So if we go to another measure, let's just go to another one real quick. Which one let me pick one we're doing well in. How's that? How about, which one have we really improved a lot on?
Smoking.
Colorectal.
Well, there's a bunch, actually.
I think I saw smoking cessation had a high number.
Smoking cessation, yeah, we can do that. Sure, let's do that one. Where are we at?
Or tobacco use screening and.
Oh, there we go. Yeah. Sure, that's a good example. So what I'll do actually is I will do by month.
By the way, for colorectal screening, the guidelines have been updated to become 45 years.
Yeah, well, it's category. We can go back to that actually. Yeah, it got updated, but it's a category C recommendation for 45 to 50.
Huh.
We can come back to that. So yeah, actually, so here is month to month of tobacco use screening. Let me show one where we had a very dramatic improvement. Hold on one sec. BMI, how well we're screening for obesity. So this is actually, you can see where we, about a year ago, this is where we were, and we did some interventions in the office using the electronic health record to improve the documentation of how well we counsel patients on their weight. And you can see the increase that we've had over time. So this is a good example of where we have significantly improved. And then if we came to detail list here, we would get all the patients that are controlled and all that are uncontrolled. So not only that, you guys, but you can even do it per provider. Oh. So let's see how Dr. Murad is doing, huh? I want to say I did good, but let's see. The numbers don't lie. Numbers don't lie. You can say you're doing good, but exactly. The numbers don't lie.
Wow, good.
See, I get an A here. I need to improve in other areas for sure. See, you guys, I'm busy during the week, I swear.
Dr. Murad, at your clinic, what type of patients do you see? Like, what's the background of these patients?
Sure.
Their socioeconomic status,
Yeah, actually, Mohammed and I were just discussing this. So basically, our patients, so we're a community health center. So there are about, I want to say about 1,500 community health centers in the state of, or in the United States. So community health centers are healthcare organizations that are dedicated to serving the underserved population, or the uninsured, or the, not uninsured really, that's not really the right term, but
low income,
patients who potentially are underserved, where the majority of them are either uninsured or they have Medicaid. Okay. Where these patients would have a difficult time accessing healthcare and other, by normal means, because they don't have, they may not have insurance, or they're, because of their financial barriers. So community health centers receive funding, they receive grants from the federal government to help subsidize this care. So in our organization, about 55% of patients are uninsured. They have no insurance. About 25 to 30% of our patients have Medicaid. So now you're looking at about 20%, in between 20 and 30% of patients who are other. They may have private insurance. Let's see, if we're talking about 25, 55, 80, yeah, about 15%. Sorry,
Yeah.
that makes more sense actually.
Yeah.
About 15% of patients may actually have insurance that's not Medicaid.
Okay.
So, about 40% of our patients are maybe not even 40. I have to double check, but many of our patients, it might be a majority. Actually, hang on one sec. I have this data. Sorry, guys. This is stuff I should have off the top of my head. My goodness. But it's just like medicine. If you don't have it memorized, just need to know where to look it up. Okay. So I can tell you that our patients were, because I really want to tell you the percentage of our patients that are Spanish speaking only. It doesn't even have it, man. So it's probably more, well, I'll tell you this. About 11% of our patients are African American. 83% of our patients are white, but white includes Hispanic, actually. There's a difference between race and ethnicity. So yeah, Mohammed, if you ever come here, you'll get used to it. But race and ethnicity. Race is white, but ethnicity is Hispanic. And that refers to if you speak Spanish primarily. So 83% of our patients are white, but the vast majority of that 83% is Hispanic. So it probably, I got it. Okay, 46% of our patients are Hispanic. Okay, I found it. I knew it was 40 something. I knew it was 40 something. So 46% of our patients are Hispanic. Just to give you an idea, and the vast majority of those Hispanic patients are Spanish speaking only where they don't speak English. And then yes, I'm correct. 56% of our patients last year were uninsured. 28% had Medicaid. Our health center is a place where it's not just seeing patients in the office. We need them to get imaging. They need to get procedures. They may need to see other specialists. We need to do stuff for them in the office. We need to do office procedures for them. We need to do comprehensive women's health. We need, also my organization, it's not just medical, but we also have dental services and we provide mental health services as well. And that includes substance use disorder. So if patients are addicted to alcohol or opioids, we can provide treatment for those conditions. And also we have we have a staff that includes clinical psychologists, that includes other behavioral health clinicians that can do integrated behavioral health visits as well. So anyway, that is very similar to community health centers across the country.
Good. Thank you.
Answer your question?
Yep.
But
Thank you,
I will tell you though, as a community health center, these are the same quality measures for all community health centers, or very close to it. Very close to it. This BMI, depression, colorectal cancer. Actually, colorectal cancer is a difficult one. It's a difficult nut to crack, actually. And let's see how we've been doing in that. So if we look at it month to month.
Is it under the baseline?
Yeah. So network average is 46.
What counts as colorectal screening for this purpose?
Either a FIT kit, either to check for blood in the stool, or a colonoscopy.
A cold stool, okay. And are people usually decline colonoscopy because of
because they can't afford it.
They can't afford it. Okay.
That's Okay. Normally,
even the occult blood test, because that you take home with you.
That we
give people it.
Yeah, that we can do. Yeah, exactly. So yeah. So yeah, let me just take a look here. Now I'm curious as we're looking through this, actually. 40.7. Okay, good. That's a good increase, actually. I just want to make sure we increased from first quarter when we did. So good. Okay. Anywho, yeah. So anyway, as you can see, you can slice and dice. And then as you can also see, you can check by provider. So let's see how Murad was doing for colorectal cancer, shall we? So these are examples of registries that help you improve your practice. No, I did my part. That's all I can say.
Oh yes.
So
Yeah.
as you can see, you can say, oh, look at where we're at. Well, my goodness, we need to improve on this. So, and that's what so as you can see, you can do things in the office to improve. So this is how registries can be used. So, all right, guys,
Yes.
any questions on that?
And this is separate from the EMR system, right?
So it interfaces with the
It-
EMR, and that's why healthcare IT is very important. Healthcare IT helps you to develop these platforms. Actually, this platform is another vendor, but they interface with the EHR so that whatever happens in the EHR can be reflected here.
Okay.
All right, good. Every organization will have something like that. Did we read the answer to this?
Yes.
Yes, we did. Okay. All right. So this is the last one. Okay. Regarding adapting your practice to dealing with the complexities of patients with multiple morbidities, all of the following are true except. Is it A, as the population ages, the problem of multiple morbidities is generally exacerbated? B, implementing a self-audit and feedback function is well, there's a typo there. Let me fix that. In a practice, I should say in a practice. In a practice is a valid way of assessing overall practice performance. C, using information from administrative data sets provides more than adequate understanding of practice performance in treating different conditions. D, enlisting all practice members in quality-focused initiatives builds practice capacity for dealing with patient complexity. Or E, understanding the epidemiology and interaction of multiple risk factors is increasingly important in patients with multiple morbidities. What would you say? Now,
What does choice C mean? As in administrative data set provides. What would that be?
Sure.
An administrative data set.
Right? And just keep in mind, it says all of the following are true
Except.
except.
Yeah.
Now, C, administrative data sets. So I would say that that would be similar to to what we just looked at.
Oh, okay.
So when you have a quality platform like that that looks at quality data. By the way, that platform is not just quality data; it looks at a whole host of practice-related data. How many patients somebody sees, what's their no-show rate, things like that. One thing about healthcare, the medical industry, is that there's no shortage of data. It's data galore. Using the data appropriately and having meaningful data is another thing. But anyway, I think that's kind of the types of things that C is referring to.
So how about B as the answer choice?
What's that now?
B?
Let's see. Implementing a self-audit and feedback function in a practice is a valid way of assessing overall practice performance. So, so you think B is the answer, Horam?
Sure. Yeah, I guess. Yeah, I don't because it said implementing a self-audit. So I don't know if you would self-audit to see how well you're doing or get it.
Okay, nice point. Mohammed, what do you think?
I agree with Khurram.
Yeah. Okay. Let me see what I would pick. As the population ages, I think A sounds reasonable.
Yeah.
B, I definitely see what you mean with B. C, using information from administrative data provides more than adequate understanding of practice performance in treating different conditions. Huh.
Oh, that's sounding a bit more like the answer to.
Yeah, more than adequate understanding.
Yeah.
Makes me
The way they're phrasing it.
Makes me pause. D,
Okay.
enlisting all practice members and quality-focused initiatives builds capacity. I think so.
Yes, and E as well. Yeah.
E, yeah, E certainly makes sense. So yeah, you kind of
Okay.
Kind of take it down between B and C.
I like to switch to C.
If you had absolutely no time to think about it,
I'm
probably
going
pick
with
C.
C.
That's a good test-taking
Yeah.
tip. So let's go with C. Let's see what happens. Number 7 is C. All
It is.
right.
Okay.
Okay. So let's see what our authority here says. So, as the population ages, the problem of multiple morbidities is exacerbated. That's pretty straightforward. Many clinicians have implemented a self-audit and feedback function in their practice, and they have found these to be valid ways of assessing overall practice performance. You know what's interesting? A lot of times these questions are phrased, I think a lot of times we're used to working in organizations. I think a lot of times the questions are sort of phrased as, this is like your private practice. You know what I mean? So if it's like your private practice, if you do an audit, it's a self-audit, because it's of you.
It's of you.
So I think that's sort of the lens that a lot of times the questions are in. In any event, many clinicians have implemented a self-audit and feedback function in their practice, and they have found these to be valid ways of assessing overall practice performance, which would agree.
Yeah.
The use of information, so here we go, it's talking about C now. The use of information from administrative data sets is an attempt to provide an understanding of practice performance in treating different conditions has been a common practice of insurance companies for many years. However, these databases have been fraught with poor quality of data and are generally inadequate to measure individual practice or provider performance. Combined with chart audit, they become more useful. Enlisting all practice members in quality-focused initiatives builds practice capacity for dealing with patient complexity. And of course, it's just rephrasing D, understanding epidemiology, and the interaction of multiple risk factors is important. So is important for multiple morbidities. So E is just, E is true. So very interesting. What do you guys think about that that commentary for C?
Yeah, it makes more sense one day, I guess. But so I guess the reason it's not the answer is because it says more than adequate understanding of practice. So I think that's
yeah. When it says more than adequate, yeah, that kind of gives you pause. Gives you pause. I mean, I think, like, for example, when people, like, as physicians, will have dashboards of our performance, okay? And when we have dashboards of our performance, they're not, like, a lot of times the data is based on a small sample size. So automatically, it's kind of questionable how valid they are. Mm-hmm. And insurance companies can have similar dashboards. Insurance companies, by the way, they operate based on claims, okay? So insurance companies, they don't have your EMR. Like they don't have it, basically. What they have are claims data. So every time when we see patients and we bill for them and code for them, that stuff goes where? Goes to if a patient has insurance, it goes to the insurance company. So that is the data, that is the limited data that insurance companies have. So let's say that, for example, like us, most of our patients don't have insurance, okay? Claims data by insurance companies really is not reflective, except for a very small portion of our patients, right? Mm-hmm. So that type of administrative data set is maybe not as good. Perhaps the platform that we have that I just showed, that is directly from our EHR, that's probably somewhat better. So we're always looking to improve these administrative data sets. But there's always issues. And I'll give an example. There's one particular measure that we're looking at in our organization, which is what percentage of our schedule slots are filled. Okay? And you know what? We actually don't have a good way to measure that. And that's a basic measure, but we don't have a good way to measure. We have a way to measure it, and we have been measuring it that way, and it's been okay. But could it be better? Probably. Is the way it is now 100% accurate or valid? I should say probably 100% valid. Questionable. So are you going to make huge decisions based off of it? That's questionable, right? So, so even with this fancy platform, there's this one really important measure that we're having a hard time measuring accurately. So that's why administrative data sets, it's like, a lot of times you do get a measure, but is it a small sample size? Was the method that it was collected really a good way? Is there a better way? So if that's the case, how useful is that measure? So there are limitations there. And I anticipate that as time goes on, those administrative data sets will continue to improve. So, good. Any questions on that? Okay. So, yep, answer here was C.
Yes.
Okay. But in general, though, while it's true, sometimes data sets need to improve. Sometimes there are good data sets. Like the platform we just showed, those are pretty good. Although, even having said that, sometimes, you know, sometimes we talked about an interface, right? We talked about an interface. With the interface, if it's not interfaced properly, then even that data becomes questionable, you know? So while, again, it's getting better, but and it probably will continue to improve. So anyways. Okay, guys. Well, I think that is kind of that's kind of it. Let me see here. If there's anything else from my organization I could share. I guess that's kind of it. Yeah, I guess that's kind of it. So, okay, what questions do you guys have regarding this topic?
Maybe I wasn't here for this part, but if you're managing multiple morbidities and you need to get your patient out to see some type of specialist, cardiologist or endocrinologist, and like they don't have the means to see that, or how are you, like what happens then?
Absolutely. Very, very relevant question, Joram, actually. So there are a few things. Okay. I guess there are a few different options. Option number one, let's say a patient does not have the means to see a specialist, which, by the way, we see all the time. If a patient doesn't have insurance, good luck, okay? So what do we do? Well, option number one, is there a colleague who's also a family physician in your practice that has experience with this condition? So don't overlook a colleague in the same organization. Maybe that colleague can deal with it. So the patient can either see your colleague, or perhaps you can just ask your colleague, all right? And then that leads to the second option. Maybe it's not so there's looking within your organization, and then there's looking for recommendations outside of your organization. So as physicians, we develop a network. And we have a network. It might be personal contacts. It might be someone you've met professionally, but you still have their cell number or their email. And you reach out to them. You say, hey, I've got a patient. And honestly, I can order the stuff. Like if I need to order a thyroid scan, I can do it. If I need to order a PET scan, I can do it. You know, I can do it. I just need to know what's the most appropriate thing to order. Mm-hmm. I just need a little friendly advice. So, colleagues in the hospital, right? Sometimes if I have their cell number, I'll call them, I'll text them even, Or sometimes I'll page them in the hospital. They're not in my group, but I see them at the hospital. I work with them. I've referred patients to them before. That's something else you can do. You've referred patients to other people before. You might have a relationship. You might just call them up. Say, hey, I've got this patient. I can send them to you, but I'm just wondering, what would you recommend? So there are those kinds of contacts. By the way, I'll also put in a plug for working with students. What happens when you have students is eventually they grow up and they graduate and they become big shot specialists. So I keep their numbers. So I remember like 10 years ago, students that I've had, they're all sorts of things now. They're dermatologists, they're surgeons, they're endocrinologists, infectious disease specialists, just all sorts of things. So I'm like, yeah, I was your teacher. You need to answer my call. So that's another good reason to go into teaching, by the way. You have your students grow up and they become, they go into their specialties. And what that does is that adds to your network. Okay, that adds to your network. So what did we say? Option number 1, see if there's someone else within your organization. Option number 2, you leverage your network as much as you can, whether it's personal or professional. Give them a call, and a lot of times you'll get friendly advice that way, okay? Now, option number 3, something that is becoming more common nowadays is there are online consultation services for organizations. So especially for a community health center like ours or other primary care organizations, what if someone doesn't have a formal network and you just need some information, you just need some friendly advice? Then you can get that in a formal way. And there are companies where if you sign up with this company and they have like a monthly fee or something, you have access to a range of specialists that you can get like on a Zoom call or something like that and get that information. So it's where you don't have, it's not you're using an informal network of colleagues, but you are formally reaching out to colleagues where they provide friendly advice to you to help you manage your patient. So those are 3 ways that I see that we can get specialty input when we can't get a patient in to see a specialist. Now, certainly if a patient has to see a specialist because, like, I'm sorry, they need their gallbladder out, they need their uterus out, then that's just a matter of, you kind of have to hash it out with that doctor's office. So.
And in the state of Kansas, they have not expanded Medicaid?
No.
They have not, okay.
Nope.
Even under, not even under like the Biden plan or anything like that?
Nope.
No, they have not, okay.
Nope. Have no hope that they will.
They have no hope they will, okay.
No, not really. So yeah. Good.
Okay.
Good. Any other questions?
Expanded to
I had a person.
Go ahead.
Expanded to mean to include people with a bit higher income?
What's
to
that
be
now?
covered by Medicaid?
No, Medicaid would be low income only. Yeah.
Yeah, so when you said expanded, it means it's covering people with a bit higher income?
Yeah, there's still
With a little bit more, yeah.
Yeah.
Because like if you look up Medicaid poverty line,
yeah,
it's like if you make more than $16,000 a year, you don't qualify for Medicaid as a single person, but like, which is, yeah. But if you just look Medicaid poverty line, it'll tell you like, in 2021, if you're making more than this, you can't get Medicaid, unfortunately, and you have to be, all that.
Wow.
And Dr. Murad, I know you said that you did OB as well. So if you have an OB patient with multiple morbidities, will you outsource that to a MFM specialist?
Well, it's interesting, Khurram, you mentioned that. Basically, that's one of the things that, that's another one of the times where I'm very I feel very fortunate to be a family physician because when an OB patient comes in, we are well equipped to deal with a range of things
Yes.
that the patient may have.
I was actually thinking that the other day, doctor, because like when I did OB, like
Mhm.
she was a general OB, and then she was just like referring a lot of cases out to MFM.
Yeah.
Some understood. There were some patients with lupus,
Right.
but like I'm like, all right, she has hypertension, but does she need to really see a cardiologist? You know, like,
Right.
yeah.
Yeah. No. In my experience, we routinely cared for pregnancy with gestational hypertensive disorders, which includes gestational hypertension as well as chronic hypertension. When it became preeclampsia, managing those things in an inpatient and outpatient setting,
Okay.
diabetes, pre-gestational diabetes, as well as gestational diabetes, diagnosing them and managing them. In fact, at my organization, we had something called a complex OB clinic. And with the complex OB clinic, it was manned, I remember, I don't know, maybe 10 years ago or so, but it was staffed by an OB-GYN. And this is in an academic institution. So, you know, the spectrum was a little bit broader for everybody, but a general OB-GYN did this complex OB clinic where the gestational hypertensive and gestational diabetics, would be seen and cared for. And it's not just those, but other complications as well, infectious diseases, other obstetrical or other, I should say, medical comorbidities, such as if a patient had asthma or lupus, or other medical comorbidities. Maybe not hypertension, but maybe like a cardiomyopathy.
With these,
Well, cardiomyopathy, I better stop there. No, cardiomyopathy,
yes.
that's definitely MFM. I should not let me not get carried away. But anyway, the point is that we had this complex OB clinic. So the OB-GYN, he, really nice guy, he moved to another state. So we have an OB fellowship. And in this OB fellowship, we teach family physicians how to do C-sections, but also how to care for complications in pregnancy, whether they're obstetrical or medical comorbidities. And so when he left, I was like, can I do that clinic? And then he was like, yeah, sure, if you want. And then I talked to my supervisor. He's like, yeah, don't do it by yourself. Okay, we'll help you. In fact, it became part of the OB fellowship, in fact, where the OB fellows themselves got trained in dealing with the different complications and comorbidities. So, so this is something I very much enjoyed. There are times where we diagnosed diabetes for the first time, a new diagnosis of diabetes in a patient who's pregnant, and also diagnosing different connective tissue disorders even. Oh, yes. Stuff like that. What if a patient had rheumatoid arthritis? Now some things you may need to see an MFM for a visit, possibly.
Yeah.
But no, we would take care of a lot. Now to do that though, your organization has to be supportive of that, and your OB-GYN backups need to be supportive of that. If they're not supportive, then your scope of practice may be restricted depending on that. But anyway, yes, as a family physician, I actually felt well equipped. As long as I received training for those things, then a family physician is well equipped to handle a lot of these things.
Okay. I remember I asked my own personal family care doctor. I'm like, hey, why don't you do OB stuff or whatever? He's like, too much hassle, too much malpractice. This was in New York though, and he said it's not worth it in New York for him to do that.
Yeah, it may be. Midwest is a little bit more.
Yeah.
I mean, heck, there's only one, maybe two if you stretch it. But granted, there's only one hospital in the Kansas City metro area where family physicians can get C-section privileges, and that's where our fellowship program is. So so that's the organization that is supportive. So in the Midwest, you have more of that.
Absolutely.
The West Coast too, I believe. So actually,
Really?
Rochester, New York, if I'm not mistaken, has an OB fellowship for family physicians. So.
Okay, Rochester.
Yeah,
okay.
Rochester, New York. Yeah. So.
Like I enjoyed OB, So I always think about it sometimes in terms of like, you know, like something like you did. Yeah.
Yeah, actually, OB is why I went into family medicine.
Okay.
Is exactly why. Otherwise, I would have gone to internal. Personally, I would have gone into internal medicine. But it was the OB that I liked that said, you know what, heck with it. Let me just do family medicine. There's a little bit of a trade-off. You know, it's like, am I going to be as good as an internist? No. But can I be close enough to my professional satisfaction? Probably.
Yeah.
Probably. You know, but to deliver babies, and maybe you won't do inpatient procedures, but you do a heck of a lot of procedures. I mean, there's no
You
lack.
still do ICU decent?
Oh yeah, oh yeah,
Yeah.
all the time. Oh yeah,
Oh,
definitely.
yeah.
Yeah. So there's no lack of procedures. It's just what type.
What
So
type?
it's a trade-off, and who knows? Maybe if I mean, it all depends on what you do after training too. But anyway, I think to be in academic medicine, it's a little bit easier to do those things. Is my
Absolutely.
experience. But yeah. So. But yeah, no, I love family medicine. I love it. And actually to do the Medina Clinic, which is a charitable clinic, I wouldn't have been able to do it if not being a family physician. If I were an internist, wouldn't have been able to do it. There's no, well, I shouldn't say that, but it would have been harder. Definitely would have been harder.
Yeah, for sure.
Yeah, it would have been harder. Somebody comes in with a skin thing, I'm like, yeah, I don't know. So that's if I were an internist. But being a family physician, you can. Not a knock on my internist colleagues. They're brilliant. They're absolutely brilliant. So, but I think for an interest in charitable medicine and free clinics and things like that, being a family physician, it was very good for that. And so I'm very grateful for that. So. Okay, guys. Well, I tell you what, looks like we've hit our 2 hours. Any other questions at all? All right. Well, I'm sorry, Jorge?
Oh, that's it for today for questions.
All right, that's it for today. That sounds good. So you guys have a wonderful week. Bear with me. I do apologize for last week. Let me try and get some slides out for next time. And I will post this on YouTube as soon as I can. So.
Awesome. Do you know what the topic is for next week, Doctor?
Oh, yeah, absolutely. So the topic for next week, and which I'm very excited about, actually, it is, I have to look it up. I'm very excited about it, but I have to look it up. I want to say it exactly right. It's quality improvement.
Quality improvement. Okay.
Yes. So I'm looking forward to that discussion.
All right. Likewise, Doctor. Thank you for today.
Thank you, guys. Have a great one.
Have a great weekend. Bye, Mohammed.
Bye-bye.
Bye-bye.